So good morning, everybody, again. Welcome to this morning's VIVA Asia Educational webinar on the current concepts in the biology and treatment of LCH. So I'm Teresa from VIVA, and I'll be your host this morning. So for those who are new, the VIVA Foundation for Children with Cancer is a charity focused on saving the lives of children with cancer through excellence in research, medical care and education in Singapore, Asia, and beyond. So as always, we hope that today's webinar will be a meaningful session for everybody. I mentioned earlier, for anyone who is new to Zoom, please to share your questions in the Q&A box and not the chat box. You can find us located on the bottom of your webinar screen. There will be a dedicated Q&A session at the end of the webinar, so we will try to address as many questions as we can. I'd like to invite our Chief Operating Officer at VIVA, Mr. Anson Chu, to make a few welcoming remarks. Anson?
Yes, thanks, Teresa. A good day to everybody. Hello. Some of us are in the Asia in the morning zone and some in the USA in the evening zone, so good day to all. Every year, we organize educational exchanges among doctors, nurses, and other medical professionals as such through our annual Jude-VIVA Forum. This webinar is part of our mission at VIVA to share the latest development in research and treatment of pediatric cancer among the medical community. VIVA believes that these exchanges are vital to save more lives of children with cancer by enabling these children to access better treatments as doctors gain new knowledge from their peers in various professional sharing. So we are very fortunate today to have a very distinguished panel of experts who are the world's best at their own respective field. Let us welcome Dr. Carlos, Professor Kwa, Dr. Michelle, and our moderator, Dr. Francis Ip from NUH. Thank all of you for your generous time and knowledge, sharing of the knowledge with us for today's seminar, webinar. I'll leave it to Teresa to introduce these experts in a bit more detail. Thanks, Teresa.
All right, thanks, Anson. So it's with great pleasure for me to introduce our chair moderator for today, Dr. Francis Yip from NUH. She's currently a consultant at the Division of Paediatric Hematology Oncology at NUH in Singapore, and also at the National University Cancer Institute. She graduated from St. Bart's and the Royal London School of Medicine and Dentistry and returned to Singapore to work and train in pediatrics. Her clinical practice involves general pediatrics and all aspects of pediatric hematology oncology, including bone marrow transplant. She has a special interest in the area of bone marrow transplants, especially that of non-malignant transplants and immunodeficiencies. So I'd like to turn over the floor to Francis, who will introduce the webinar as well as our speakers and panelists for today.
Okay, thank you, Teresa and Anson, for the very kind introduction. So I'm really glad to be able to chair this session today. And I think Dr. Carlos Rodriguez-Galindo needs no further introduction. We all know him very well. Dr. Carlos is the director at St. Jude Global, as well as the associate director of the St. Jude Global Outreach Cancer Center. His main interest and his main patients that he looks after are pediatric patients, in particular solid tumors. He's the principal investigator of multiple institutional trials focusing on NPC, LCH, germ cell tumors, and he is especially interested in the development of pediatric oncology in countries that have limited resources. He does active work in program building, research, and education. Dr. Carlos also just published in Blood 2020 a really nice review on LCH. And I think without further ado, I'll let Dr. Carlos tell us today more about LCH. Thank you.
Thank you so much, Francis. I hope that everyone can hear me well. And also thank you very much to the VIVA Foundation with Jennifer at the head, and then with Ansu and with Teresa and Sally as well for inviting me to be part of this. And thanks my panelists, Prof. Kwa and Michelle Hermiston, who I appreciate and admire a lot. So hopefully we can have a nice conversation today. So over the next half an hour or so, I will try to provide you with a brief update of where we are right now in our understanding of the biology of Langerhans cell histiocytosis and the treatment of Langerhans cell histiocytosis, because I believe that most of the attendants are pediatric oncologists, pediatric hematologists, and nurses that are already familiar with LCH. I may spend less time on some of the key concepts in the presentation and evolution, but hopefully during the time that we will talk about treatment and biology, we may just have some time as well to go over some of the clinical features. So let's start then with these, and hopefully we can all at the end, engage in a conversation and try to answer some questions. So what is Langerhans cell histiocytosis? So we now know that it's a clonal proliferation of the Langerhans cells. We know that multiple organs and multiple systems can be involved, and that the clinical presentation and the outcome are also very variable. So over the years, maybe more than 100 years, there have been multiple different syndromes that have been associated with LCH, starting with eosinophilic granuloma that has progressed then to more understanding of skin disease, polyostoric bone disease, some diseases that had different names like Hanschel-Christian or multi-system disease and lateral sieve disease. All these diseases that had different presentations, different forms, different severity, at the end of the day are part of the same syndrome that goes from very mild and almost self-remitting disease like eosinophilic granuloma to a very advanced multi-system involvement that can be lethal to the patients like lateral sieve disease. So this is Langerhans cell histiocytosis, many diseases in one. And regardless of the presentation, regardless of the severity, the histopathology is very well defined and is uniform across the diseases or across the presentations. So what we do see is a collection of these pathologic Langerhans cells with interdigitating cells, macrophages, lymph nodes, lymphocytes, multinucleated giant histiocytes, and eosinophils. The fact that we see so many eosinophils, as you see on the picture on the left, is what has given that name of eosinophilic granuloma. And then the diagnosis is confirmed by the presence of CD1A positive staining or Langerhans. And then in the past, the diagnosis used to require electron microscopy to detect the Burback granules, but now Langerhans basically is a staining for those granules, so electron microscopy is not needed. So very briefly, we will just go over these four major components. How does LCH present? What is the current understanding of the epidemiology of LCH? We'll talk a little bit about how we now understand better the biology and its treatment. So I will just show 3 slides on the presentation just because Langerhans cell histiocytosis basically can involve any organ. So here on the left, you have a table with the most common organs or systems involved. The most common is the bone. Almost every single patient with Langerhans cell histiocytosis has bone disease at some point. Skin, liver, bone marrow, lungs, orbit, mouth, ear, CNS disease, or even the GI tract can all be involved by Langerhans cell histiocytosis. So that makes it one of the most chameleonic diseases in childhood. Here are some x-rays just to highlight some of the most common presentations for bone mostly. So the skull, as you very well know, is actually the most commonly involved bone. In the spine, you may present, or the patients may present with vertebra plana, which is basically a collapse of the vertebral body after the destruction by the eosinophilic granuloma. Long bones are very affected as well, usually the diaphyses rather than the metaphyses. The bones of the hands and the feet are seldom involved. Usually it's large bones or flat bones. I just showed as well a picture of a PET scan because a PET scan usually is very helpful for diagnosing, staging, and follow-up. Doesn't mean that we need to do PET scan in all patients, but in case of doubt, a PET scan works very well for Langerhans cell histiocytosis. And outside of the bone, a very common presentation is the lung in children. Children with multi-system disease in general might present with lung disease, and you can see this pattern of a mixed nodular densities with emphysema and cysts. And then another very typical presentation is CNS. So in the brain, LCH can affect the brain by direct infiltration of the brain with what we call tumours disease. But what I showed here in this X-ray, in this MRI, I'm sorry, is a very unique presentation that it's long-term effect of Langerhans cell histiocytosis that we'll talk a little bit later, which is neurodegeneration. And so this is how LCH may present from a single bone lesion to lung disease to neurodegeneration 10 years after the disease was treated. And here I have some pictures that for those that are pediatricians in the room that can help as well diagnose LCH, a presentation during infants. And LCH may present with very severe skin disease. On the upper left, you have cradle cap disease, like seborrheic dermatitis. You may also see different forms of maculopapular disease, oftentimes affecting the intertriginous areas, that is the axillary folds or the groin. In the middle and the bottom, you see a very typical presentation in an infant, as you can tell, with a very severe hemorrhagic erythema in the diaper area, and you can tell actually this child has hepatosplenomegaly. So that's a typical presentation of multi-system disease. And then on the left-hand corner, I would like to highlight as well that although very rare, LCH may also involve the alveolar ridge, the mouth, and that has been associated with what we call the floating teeth syndrome, where the teeth may actually be dislodged or displaced. So that's a very common presentation as well in young children. So these are just the 3 slides I'm going to show about presentation, because we had more to talk about the biology and the treatment, but just during the talk, we'll talk a little bit more about this. So what is the incidence of LCH? So we don't really know that well for one basic reason, which is that Langerhans cell histiocytosis until recently was not considered to be cancer, and for many it may still not be considered cancer, and therefore cancer registries would not capture it that well. So you have to rely on other type of registries and databases. So there is not a very good knowledge, and of the few papers that have been published, you can see here the incidence varies from around 2.6 to up to 9 cases per million children younger than 14. So this incidence is very similar to Hodgkin's disease, for example, or 3 times the incidence of liver cancer in pediatrics. So it's not that rare. So it's a disease that actually should be recognized more often than not. So in the United States, the cancer registries only have captured what we call disseminated LCH. That's the only code that is included in the ICD-03. So you cannot capture single site or bone only disease. But so disseminated LCH has an incidence of about 0.6 per million per year, but what, as you can imagine, has a very significant correlation with age. So multi-system LCH is basically a disease of the first decade of life, basically the first year or 2 of life. And so here you can see how the incidence is much higher, about 5, the annual standardized ratio, about, 5 cases per million per year, and then it drops precipitously after the first 5 years of life. But what is interesting is that at least in the United States, and it's something important as well to discuss in Asia, is that we see 2 important variations in terms of incidence based on ethnicity and race. For example, the incidence of multi-system LCH is much higher among Hispanics than non-Hispanics, almost twice as high in Hispanics as it is in non-Hispanics, as you see here. And the opposite happens with the Black race. So the incidence of multi-system LCH is almost 5 times higher among whites than among Blacks in the United States, Whether this also correlates with the incidence across the age group or across presentations is not so clear. But in general, for pediatrics in multi-system disease, LCH seems to be a disease of white and Hispanics, and very few cases of blacks. So then another thing that many of us have been concerned over the years is that, sometimes we tend to see LCH associated with poverty, at least here in the United States, and it's not unusual to see LCH in lower income populations. And so when we did a study trying to associate the incidence of multi-system LCH based on the census data, looking at different zip codes, area codes, we correlated the incidence of multi-system LCH with crowding, so families that have many members living in the same space, or with lower education, so that it's in areas in areas of the country where the education is lower. So lower education, crowding, not so much poverty, seem to be as well associated with an increased incidence of multi-system LCH. Not much more is known about the epidemiology. I think a lot of questions that need to be addressed that hopefully can also be discussed for the Asia Pacific region. So let's focus now for a few minutes on the biology of LCH. So we showed that slide earlier, and that slide basically is described as an eosinophilic granuloma, multiple different cells coexisting in the same lesion. So what you see in that lesion is a Langerhans cell that actually it's coordinating an immune response that involves eosinophils, lymphocytes, and macrophages with this micro cytokine storm that generates that proliferation of cells and bone destruction. So what we know when we look at these cells is that there is typically an uncontrolled clonal proliferation of Langerhans cells. These Langerhans cells seem to be arrested in a partially activated stage with a deviant regulation of cell division and very abnormal interactions with all these other cells around them. So that has prompted for many generations the question, what is LCH? And what is the origin of LCH? So what is the cell of origin when you have this plethora of cells interacting with each other? So the cell of origin for many generations, and that's why it's called Langerhans cell, just because it's the typical cell of Langerhans of the epidermis. So it was thought to be originating from the epidermis, from the Langerhans cell. However, in the Langerhans cell lesions, we realize that these cells come from a dendritic lineage that is positive for Langerhans, but we know that this Langerhans is not limited just to the epidermal Langerhans cells. So when Dr. Allen did a significant study a few years ago looking at the gene expression across Langerhans cells and Langerhans cells of the Langerhans cell histiocytosis, it was clear that the Langerhans, so the CD207 positive cells, express several genes that are associated more with an immature myeloid dendritic cell rather than the typical epidermal Langerhans cell. So now we know that the Langerhans cell lesions do not arise from the epidermal Langerhans cell, but from an accumulation of these bone marrow derived immature myeloid dendritic cells that then recruit activated lymphocytes. So now we know that Langerhans cells come from the bone marrow, not from the skin. And we know that comes from myeloid cells. So in a sense, it's a myeloid disease. The question then that has puzzled many generations of researchers was, is this an inflammatory disease or is this a neoplasm? And I think that all of us have for many years thought it could be an inflammatory disease just because we knew of the significant amount of inflammation in the lesions, and also because we knew that in many cases the Langerhans cell lesions can regress spontaneously. And all this was a debate, and may still be a debate, but I think that this paper that was published 10 years ago, about now, 10 years ago in June of 2010, by Professor Rollins in Boston basically changed completely our understanding when he noticed that approximately 2/3, 60% of the lesions had a mutation of the BRAF gene, so that's a BRAF V600E, which is basically one of the most common mutations in cancer. So that in itself brought completely the disease into the realm of oncology because it was defined by an oncogene like melanoma or like many others. And so the question then, is this an inflammatory disease or is it a neoplasm? I personally believe that now we have reached close to a conclusion that this is a neoplasm. Could be an inflammatory neoplasm, could be a neoplasm, a low-grade neoplasm, but I believe that this basically confirmed that this is a neoplasm. Now, when you look at neoplasms in general are defined by multiple mutations, by a very aberrant genome. When you plot here the human cancers, on the right you have the adult cancers, on the left the pediatric cancers, you see that there is a continuum in which you see cancers with a very high mutation rate per megabase on the right, and on the left, cancers with a very low mutational rate. And the pediatric cancers tend to fall to the left of the curve with very few mutations. And Langerhans Cell Histiocytosis is at the very left of that graphic with very few mutations per megabase. So that is the only factor that keeps reminding us that this is not a typical neoplasm when you only see just one or two mutations that define the disease. So what are these mutations? So basically the BRAF gene kind of opened the door for that pathway, the RAS, RAF, MEK, ERK pathway. And this is the pathway that seems to be activated. So by so by activating BRAF, by mutating this oncogene, you activate the downstream pathway, MEK, ERK. But that was not the only gene. So it was about 50–60% of the cases have a BRAF mutation, 64% may have a BRAF V600E, 6% may have an indel, some may have a duplication, some may have a mutation of not a BRAF but ARF. But then you see that there are cases of mutations across the entire pathway in ERB, and the second most common is the MAPK, so in MEK, so about 12%. And we still have about 15% of the mutations that have not been described. Could be some fusions that have not been described yet. But the bottom line is that LCH is characterized by activation of the RAS, RAF, MEK, ERK signaling pathway, and that we can find mutations in different components of this pathway. So now we have a whole different way of looking at Langerhans cell histiocytosis, which is how are these mutations going to be followed or can be determining the clinical presentation. So we know that about 2/3 of the cases have BRAF V600E mutation, but there is the correlation between the type of mutation and the clinical presentation is not so clear. In the earlier studies, it looks like whether you have a BRAF mutation or another mutation doesn't seem to correlate with the risk, with the age, with the gender, with the extent of the disease, or even the survival, even though patients with the V600E mutation seem to have a slightly higher cumulative incidence of recurrence, but not so much in overall outcome. What these mutations have also allowed us is to be able to detect the mutation in circulating cells as a tumor marker, if you wish. And so we know that patients that have a single lesion don't have detectable BRAF in the peripheral blood. Patients that have multi-system disease, you may detect BRAF V600E in the peripheral blood. If you have patients with very advanced disease, with a multi-risk or multi-organ involvement, then you may have a much higher incidence of a much higher frequency of detecting the BRAF 600E in the peripheral blood. So it seems to correlate our ability to detect V600 in the blood with the presentation. And that also helps us with monitoring of response. So there is this paper already old, 6 years old, that basically helped us understand better how we can use that. And so yes, if you have a patient in whom you can detect V600 in the peripheral blood, you can actually monitor response by serial measures of cell-free DNA, looking at the type of mutation. And so now this is being used as a way of monitoring response in many cases. So that basically it's in 4 or 5 years, we were able to clarify the disease from an inflammatory disease to a cancer. And then from that point of on, able to actually use that information as well to develop better therapies and monitor responses. Then another important factor I wanted to show here, even though probably would belong to later in the talk, is how this has helped us as well understand better the CNS disease. As you know, and as I showed earlier, a significant number of patients may develop neurodegeneration, but this neurodegeneration occurs later, maybe 2 years, 5 years, 10 years after receiving treatment and being cured for LCH. And so I just would like to bring you down to the bottom of this slide, just that when we do traditionally brain biopsies of patients with neurodegeneration, we were not able to find Langerhans cells, only gliosis, only scar tissue. But now we know that we can actually, by looking at V600E, that we can find diffuse perivascular infiltration with cells that may not have positive Langerhans staining, but that are actually cells with a mutated V600E. And the second point that it's important here in biology as well is that as it has been reported recently in a couple of papers over the last 2 years, that patients with neurodegenerative disease may respond to a V600E inhibitor like vemurafenib or dabrafenib. So that's an important piece, that because I think it will help us understand better the biology of LCH, as I will show you here. So this is the ontogeny of Langerhans cells, if you wish. So in the normal body, in the normal host, the yolk sac usually produces the cells that eventually populate the brain as part of the microglia. The liver and the yolk sac generate the cells that populate the epidermis, as what we call the epidermal Langerhans cells. Then the bone marrow, through the hematopoietic stem cells and the monocytes, may replace some of those, the microglia and the epidermal Langerhans cells, after injury. So we know that there is a second way of getting into the brain that doesn't have to require a fetal liver origin for this microglia, but we know that from the bone marrow, you can actually repopulate some of these after injury. And so by serial studies looking at the incidence and the frequency of the VRAF mutations and other alterations, we think that this could explain in part how we can see multi-system disease and what we can think about understanding how the disease progresses. So imagine that these cells, as we said, originate from the bone marrow, and then depending on where and when the mutation occurs, if the mutation occurs in the hematopoietic stem cell or in a blood precursor or in a tissue precursor, you may have multi-system disease with lower risk involvement, or just a single lesion if that mutation occurs in a precursor that has already been committed to the tissue. And so that allows us to start putting it all together. And this is more or less how I would probably simplify it here. So if you have a mutation that occurs in a precursor in the fetal liver as it goes into the skin, you may have a skin-limited disease. But if it's a mutation that occurs later on in the bone marrow, these LCH precursors may populate any organ, but also may populate the brain in, replacing the microglia after injury, and that's what causes the neurodegenerative disease. So the idea is that depending on where the mutation occurs, whether it's a precursor or a more committed cell, you may have different presentation. I think that this model also helps us understand the late effects in the brain. Oops. And so that is, if we put together biology and clinical presentation, I think we can come up with these models. So we know where the mutations occur, and we know that depending on where the mutation where the mutations occur in the pathway, and then depending on where the mutation occurs, if it's a hematopoietic stem cell, a precursor, or a committed cell, the clinical presentation will change. You can have a patient just with a skin disease, a patient with bone disease, a patient with multi-system disease, or a patient with multi-system disease and risk organ involvement, that is liver, spleen, and bone marrow. So that's the concept, where the mutation occurred, in which cell, and at what time. So now we'll focus a little bit more on treatment. So I think that we have given you an idea of what is LCH, how LCH presents, what is the importance of the mutations and when these mutations occur, and then let's try to think about what is practical, how we can treat these patients. So we have talked very briefly at the beginning that LCH can present in 3 different ways, and I think these 3 different ways now seem to be explained by when that mutation occurs, right? So if it's a mutation that occurs in a very committed cell already in the tissue, you may have a single system disease, so that it's bone, skin, or lymph nodes, or lung. So it's or, that single system disease. The second step is multi-system disease. These mutations have already occurred in a precursor cell, so that multiple organs, multiple systems may be involved. And that's either in any combination of the above, bone, skin, lymph node, or lungs. But then many years ago, already, in the 1970s and 80s, it was described that patients with Langerhans Cell Histiocytosis that had involvement of a very specific number of organs, that's usually spleen, liver, and bone marrow, had a much worse outcome. And so I will not go into too much detail on that slide, but just to remember these 3 organs: liver, spleen, and bone marrow. Liver, spleen, and bone marrow. If you have involvement of those, the outcome is much worse. You can have 2 risk organs, 3 risk organs, or just hematopoietic involvement only, but the disease is much more aggressive in those cases. And that's where the concept risk organ involvement came from. So you can have single system, multi-system, or multi-system with risk organ involvement, and that is liver, spleen, or hematopoietic system. A few years ago, lungs were also included here, but as you see, lungs have been moved out of that risk organ classification. So these are basically the 3 categories, and how we need to treat the patients will depend on where they belong in these categories. So for single system disease, as you can imagine, that as you know, the treatment can be very simple, can be just topical, can be just curettage of a bone lesion, and the patients may respond very well. For multi-system disease, you need to treat the patient systemically, we'll talk about this, and for multi-system disease with risk organ involvement, you need to increase the intensity of the systemic treatment. So another thing that we know is that if you look at all these cancer registries I mentioned earlier, where all the multi-system patients are recorded, then you can see that actually we have done very well. So if in the 1970s and 80s, about 40% of the patients would die, now in the 2000s, almost all the patients survive. Probably now we can say that 95% of the patients with multi-system Langerhans cell histiocytosis can be cured. So we have made a lot of progress over the last 2 or 3 decades by improving the way to classify the patients, the way to treat them, and the way to salvage them if they recur. So if in the 1990s, the survival, the 5-year rate of survival rate was about 70%, now we are clearly above the 90%. So we talk about observation, local therapy, or chemotherapy in some cases, chemotherapy, and then intensive chemotherapy. So now we'll go with with a quick review of where we are right now with the treatment. And for that, I will start here at the LCH3 study. The LCH3 study, which follow LCH1 and LCH2 of the Histiocyte Society, basically was the first one that really came with this concept of risk stratification. So by risk organ involvement or not. So that created three categories. Group 1, multi-system disease with risk organ involvement, low risk group, then multi-system disease without risk organ involvement, and then group 3 that I will not talk right now, which is multifocal one disease and special sites like the CNS risk lesions and vertebral bodies. For low risk patients, so multi-system disease without risk organ involvement, the problem has been not so much cure, because we can cure these patients. The problem is that they keep reactivating. So the question was, can we prolong therapy, and thus prolongation of therapy decrease reactivation rates? And so the treatment was standard prednisone vinblastine with a randomization to 6 versus 12 months. And that's basically how it was. That's the standard treatment, 6 weeks or 8 weeks of prednisone and vinblastine with 6 doses of vinblastine. Then for those patients that had an intermediate response or worse, they would just repeat a second induction. If not, they move on to continuation therapy with 3 weekly pulses of prednisone and vinblastine randomized to 6 versus 12 months. For group 1, the risk patients, the problem is not so much reactivation, which also occur, but the problem was survival. Still 20-30% of these patients die because of the disease. So the question is, in that particular study, can we increase the intensity by adding methotrexate to improve the survival? And so the patients were randomized on a treatment of 12 months to prednisone, vinblastine, and 6-MP with or without methotrexate. And that's basically how the regimen looked like, the same induction, reinduction for poor responders, and then a maintenance treatment with prednisone, vinblastine, and 6-MP with or without methotrexate. And methotrexate was intermediate dose methotrexate, that is 500 milligrams per meter squared 3 times during induction or reinduction, or then low doses, pulses every week of 20 milligrams per meter squared. So these are the results that were published already 7 years ago. So for patients with risk organ involvement, the addition of methotrexate that you see on the left side of your panel did not add. And you could still see that we were able to cure close to 90% of these patients. On the right side of your panel, you see the patients without risk organ involvement, and 6 versus 12 months of therapy did not change survival, almost 100%. But then what we can see is a difference in the reactivation rate. So looking down on the right, so patients were randomized, remember, to 6 versus 12 months. So patients that received 6 months of therapy had a much higher reactivation rate, almost 60% compared to 30% for those that were treated for 12 months. So 12 months on the left, so that is for patients with high-risk disease. You see methotrexate did not add to the risk of reactivation. So the point from this slide is that intensifying with methotrexate was not helpful, but that prolonging therapy to 12 months was better than 6 months for reactivations. So with that, and that's basically the standard of care of LCH, then the LCH4 was developed, and the LCH4 was a protocol that took forever to develop, so it's already old, but hopefully will be concluded in a couple of years. But the question was, can we further decrease the frequency of reactivations by further prolonging therapy or even adding additional therapies? And can we investigate salvage therapy for low-risk disease? And how can we decrease the mortality of these patients? And so I will walk you through the LCH for the study, which is active right now, and just give you a few ideas of where the things are going. So the first was, how can we improve or decrease the reactivation rates, the therapy prolongation and an early switch to salvage patients, so to the patients with high risk. So the multi-system patients, whether they had risk organ involvement or not, all came together in the same trial. So if they responded poorly, immediately they switch, for those patients with risk organ involvement, early switch to salvage therapy. Everyone else gets a second induction. What I wanted to show you is the second part of the slide, but then is a double randomization. So it's 12 months versus 24 months. So see if 12 were better than 6, are 24 better than 12? And then the addition of 6MP. So you have 4 groups. Patients that treated for 12 months with prednisone vinblastine, patients that treated with 24 months with prednisone vinblastine, patients that treated with 12 months with prednisone vinblastine and 6MP, and patients that treated for 24 months with prednisone vinblastine and 6MP. So hopefully when the trial concludes, we'll know if 24 months are better and whether the addition of 6MP is better as well. And then for patients that have low risk reactivation, so reactivation in low risk organs, the treatment is with RSC and vincristine with a randomization to indomethacin or 6MP and methotrexate. We'll talk about indomethacin a little bit later, a total of 18 months. For patients with high risk reactivation, that is patients with liver, spleen, bone marrow involvement, the treatment is quite intense. I will go very briefly over this. Many of you have already seen this paper from Dr. Donadieu that showed that the combination of 2-CDA, so that's cladribine with RSC at these doses, pretty high doses, 9 milligrams per meter square of CDA, 2-CDA every day, and then 500 milligrams per meter square of RSC twice a day. It's almost like an AML type of therapy, resulted in excellent outcomes, excellent survival rates, so close to 90%. But note that at least there were 2 patients that died of toxicity. That's the last thing you want to do. So it's a very effective regimen, but it's a very toxic regimen. And so that was brought to the LCH for a study. I will not show you this, but basically it's similar to the paper that was published using the same doses and then a risk stratification based on the response. And then for those patients that do not respond well, go to a stratum that includes hematopoietic stem cell transplant. What I want to show for this group as well is that there was another paper that was published a few years later from Professor Breyer in Argentina, showing that at much lower doses, this combination is also effective. Cladribine at half the dose, cytarabine at 1/5 of the dose, so 5 milligrams per meter square, 100 milligrams per meter square, also in patients with multi-system disease and risk organ involvement, and they also respond quite well. So I think it's a combination to consider in some settings where the resources for supportive care may be more limited. A low dose combination may be as effective. And then there is this big challenge that we call, which is the LCH of the central nervous system. So patients that present with endocrinologic sequela, with neurologic sequela, neurodegenerative disease that we have discussed. I will refer you to a paper that was published. Michelle and myself were part of this paper that puts it all kind of together in a summary of what is our current understanding of LCH, how we evaluate the patients with brain LCH, and how we should treat them. So I'm happy to share this paper with anyone that might want it. We can put it in a file for you. But this is basically the big question: how to treat, how to diagnose, how to monitor these patients. The protocol is an old protocol that basically randomized patients based on presentation. So patients with tumours lesions, they get treated with 2-CDA, patients with neurodegenerative lesions with RSC or IVIG. But I will tell you more about this because I think these patients should be treated with a BRAF inhibitor if they have a BRAF mutation. And then the protocol is closed with this follow-up study that basically all patients can be included. And then very briefly, because I realize that we don't have too much time and I have taken too much time, I would like to go very briefly, and I will have to apologize for being quick over this, but what is coming? What are the other therapies for LCH? One, cytarabine alone. So cytarabine alone, RSC alone, can work very well for LCH. In patients that you cannot give prednisone or they do not tolerate prednisone and vinblastine, single dose cytarabine 100 to 170 milligrams per meter square for about 5 days works very well, and it's my preferred choice for salvage. The second is clofarabine. That's another nucleoside analog that has shown it probably to be more powerful than RSC, and I recommend it for patients with more advanced disease, but it works very well. Problem is that it's very expensive and very difficult to get, but 2-CDA and clofarabine work very well. Another idea that was brought up by Dr. McLean recently is simple hydroxyurea. Hydroxyurea that we use for patients with sickle cell disease at the same dose seems to work quite well for patients with relapsed LCH. So there was a letter to the editor in Blood a couple of years ago that showed that, you know, close to 2/3, if not 70% of the patients responded, either a CR or a PR, with just hydroxyurea. That's an oral medication, very easy to administer. I recommend it oftentimes when there are no better options. Another treatment is influencing, you know, the metabolism of these lesions in the bone. And so, as we now know, Langerhans cells can induce bone lysis by activating IL-1 or PGE2, bone resorption or osteoclast activation. And so bisphosphonates and indomethacin can affect both pathways. And so there are papers that show that indomethacin may work, and that's Dr. Breyer from Argentina. That's simple. Indomethacin for a patient with a bone lesion or multiple lesions may actually work. And then the same with bisphosphonates. There are many studies on bisphosphonates, and I recommend it for patients with multiple recurrences of bone-only disease. But usually in adolescents or young adults, it may be easier to administer. But many pamidronate, etidronate, also zoledronic acid have been shown to be effective. And then finally, the BRAF inhibitors. And so I think we need to conclude with that. So there are plenty of data right now showing that all patients that have a BRAF mutation respond to a BRAF inhibitor. So that's as clear as you see on that panel, that all the cases responded. So in this study that was published by Dr. Donadier, 54 patients, 44 of them with risk organ involvement, and so very sick kids with liver, spleen, bone marrow, almost all of them responded at 8 weeks. The problem is that as you stop the medication, the majority of patients reactivate. So it's probably not curative. It can cure a small number of patients, but probably not all patients. But in a patient that is very sick with multi-system involvement, risk organ involvement, a BRAF inhibitor can induce an immediate dramatic response that you need to figure out how you want to cure this patient, because you cannot keep this patient with vemurafenib for life. Well, these patients then might need chemotherapy or a combination of chemotherapy and a BRAF inhibitor. And so a similar study was published also by our group, just a survey of patients that were treated with a BRAF inhibitor, and also showing though that the moment you stop the medication, the disease reactivates. So it's basically the same. Then I wanted to conclude with this one. And so I saved this for the last, just because what we started with the biology suggesting that, you know, now the biology has allowed us as well to understand better how the neurodegeneration in Langerhans cell can be explained as well by the infiltration of these BRAF positive precursors. Now we know in 3 of these cases, for example, how the neurodegeneration may improve, sometimes dramatically, with a BRAF inhibitor. So not all patients respond, but it's worth considering because these responses cannot be achieved with chemotherapy. So in a patient with a neurodegenerative disease, I think it's worth as well considering. Now, we don't have BRAF inhibitors for everyone because not everyone has a BRAF mutation, but now MEK inhibitors can be used for that. And finally, you know, now is the time for CAR T cells. Yes, maybe in the future there will be an opportunity for CAR T cells. And so I will conclude here. So as we know, LCH presents with this wide spectrum of disease. The treatment with the standard vinblastine prednisone can cure close to 90% of the cases. Still 30% of the patients relapse, and we still have several challenges: how to treat the patients with more advanced disease, how to manage reactivations, more therapy or longer therapies, how to manage neurodegenerative disease, and then the most important question, the million-dollar question, is how to bring BRAF inhibitors and MEK inhibitors into the frontline therapy, knowing that, you know, we cannot cure patients just with them. They need to be combined with chemotherapy because the moment we stop the medications, the patients may actually reactivate. And so with that, I will conclude, and I thank you all for your attention.
Thank you, Carlos, for the really enlightening and fascinating talk. Thank you for bringing us through the biology, the treatment and management of LCH. I'd just like to invite everyone to put in their questions into the Q&A section. And then I would also like to introduce our two panelists today. We're very glad to have Prof. Kwa. I think Prof. Kwa again needs no introduction. He's my boss, and he's also the senior consultant and in Division of Pediatric Hematology and Oncology. Prof. Kwa's famous motto is to eat, sleep, pediatrics. And Prof. Kwa has been trained in pediatrics since 1976 and has been practicing hematology and oncology initially under Prof. Wong Hock Boon since 1983. As Prof. Kwa would say, he likes everything that is fascinating and exciting. So leukemias are a little bit more boring to him. LCH is definitely fascinating and scary to many of us who don't know how to treat it. Yeah, and so we're very grateful to have Prof. Kwa here today with us. Dr. Michelle Hermiston is the Associate Professor of Pediatrics from UCSF. She's really passionate about teaching and education. She's also the Director of Immunotherapy Program in UCSF, and she's a member of many organizations, including ASH as well as American Association of Pediatrics. So Michelle is also kindly here today to help us to answer any of the questions that you may have. So without further ado, maybe just to the first question from Mei to probably to Carlos. The question is, do you reduce the dose of chemotherapy when given in combination with vemurafenib, and do you see more toxicity when vemurafenib is used together with chemotherapy?
Yeah, this is a very good question. I personally don't have experience more than just one case where I combine chemotherapy with vemurafenib. Like for everything in pediatrics, we need to do very careful. We need to be very judicious in how we combine chemotherapy. And so technically we should have the proper design for that, properly study, properly designed to look at doses and toxicity. Right now, the data that we have is that in general, these are non-overlapping toxicities. And so that depending on which chemotherapy you use, it's safe to use chemotherapy, standard chemotherapy with a BRAF inhibitor. But if you try that, I would be extremely careful in monitoring for toxicities and adjusting doses very judiciously. Maybe start with a lower dose. I would not modify the dose of vemurafenib or dabrafenib. I would maybe then start a lower dose of chemotherapy and increase. I don't know if Prof. Kwa or Michelle have had more experience with that.
Michelle and Prof?
Yeah, I have them.
Okay, Michelle, ladies first.
Go ahead, Prof. Kwa.
Prof.
Yeah.
Michelle
Yeah,
asked,
you go ahead, Michelle. I always love to hear from you.
I don't have that experience either. We've only used it as single agents alone at this point, and I really think that question needs to probably be asked in the context of a clinical trial so we can learn something.
Yeah. In my experience is, if it works alone. As Carlos said, you try not to mix in stuff which you don't, and which nobody understands very well. Yeah.
Yeah, as I said, this is the million-dollar question. Yeah, that's the challenge that we all have for the next decade. Just try to figure out what is the right combination and where these drugs can be included.
Yeah. Carlos, I'm so glad to see you again, and this is indeed a fascinating talk. And I think all of us have more questions than answers. Yeah. So one question which I want to ask you and Michelle is, when you treat your patients, do you differentiate between patients with active disease or quiescent disease? Do you consciously try to differentiate or to determine whether the patient has the active or quiescent disease?
I mean, I can start, and I would like to hear from Michelle. I agree. I said what we have learned for LCH is that many patients respond spontaneously. Many lesions may respond, and so depending on where you catch that patient and that particular lesion, you may be more or less aggressive. But many times you may just look at an X-ray and you say, "Oh, this patient has a bone lesion, but most likely this lesion was already there before, so I will not take it as a relapse or as active disease." So it's one of those diseases where you need to be very careful on how you combine the information because it keeps changing. So I agree. I think there is a difference between active disease and what is quiescent or self-resolving disease.
Michelle?
I would agree. I think part of the reason I find taking care of children and adults with LCH fun is that there's definitely an art of medicine component to this,
Yes.
where you really need to think carefully about the patient. I sort of feel like there's kind of two ends of the spectrum to LCH. There's the patients who are going to have the one single lesion, it'll go away if we don't touch them, and that's probably best for them. And then at the other end of the extreme are the patients who have really severe multi-system disease that is very aggressive and can be lethal. And then there's those patients in the middle that I have what I call pesky LCH, where it kind of just keeps back and showing up in a new place. And those patients, I think it depends how it's coming back and how it interferes with their quality of life. Some of those patients, if you really want to eliminate the cell that is causing their disease, probably develop their BRAF or MAP kinase pathway mutation earlier in ontogeny of the myeloid lineage, are going to need some chemotherapy. I guess the approach I generally take and what I discuss with families is, unless it's a child who's super sick and it looks like this could be potentially lethal, to start with less, and you can always change, you can always go up. But that's my general approach, is to respond to the patient and to kind of escalate therapy as the child dictates.
Yeah. You see, related to this point, Carlos, this is such a fascinating disease. Fascinating because to me, every patient is different. So I presume it'd be very difficult to design a trial because there are so many variable factors. Yeah. What would you say, Carlos?
Yeah, I agree. I think the trial design for LCH has always been a challenge, and so you always need to be very careful on how to interpret the data that is published, that are published from a clinical trial. And so you have multi-system, you have risk organ involvement, then you have, I see that there is a question about liver transplantation, then you have what it's active versus what it's late effect. You have sclerosing cholangitis that may overlap with active disease, when it's active disease and when it's not, and it's a sclerosing cholangitis. And so how to decide how to treat these patients in the context of a clinical trial is challenging. I agree.
You see, you presume that this LCH cell would secrete cytokines. If it's just local, then you see the local inflammatory response. If the cytokines get into the blood, then you get the blood changes. I call this inflammatory blood picture, anemia, thrombocytosis, eosinophilia, and such things. Yeah, so this will give us, to me, some indication. And sometimes it's not so clear. So in that sense, I think the PET-CT would be very helpful. Yeah, I had this Russian boy about 3 years ago. He had this the soft tissue lesion. Yeah, just abutting on the frontal lobe. Yeah, and he responded to treatment, but this child was going back to Russia, so we evaluated him before he went back and found that the soft tissue lesion was still there. Yeah, so I wasn't sure whether he deserved the further treatment. So I did a PET-CT and it didn't pick up. The soft tissue lesion wasn't bright. So I told the mother, I think we can just watch and see. 2-3 years later, the child is still okay. And this would, I think, partly answer the question from our good friend, the Professor Hania Rifin from KL. Yeah, in my experience, all the patients who didn't succumb, who didn't die of LCH, they would burn out in the end. Yeah, I've seen them, some of them still continue to see me 10, 20 years after. I told them no need to come back, they still want to come back to see me, and they're still okay. Yeah, so I don't know whether this is the experience of a wider group of the population. Usually they burn out by their teens. Yeah. Have you seen any that continues to drag on 10 years, 20 years?
I have. So in our setting,
Michelle, you are muted.
thank you. Sorry about that. In our setting, I often will get referred adults, at least for consultation, and then make a treatment plan and then refer them back to an adult oncologist. So I think my oldest patient was 72 and had been battling it for probably 40 years. He felt very out of place in a pediatric clinic with I have a number of adults who seem to kind of have that, more what I think of as the pesky thing where they've really been battling it for years. In the adult population and the older teenagers, I tend to use more Ara-C instead of vinblastine as their initial therapy, just because they have so much toxicity from the vinblastine. And there's a nice paper that Kim McLean is on that kind of describes approaching adults versus younger patients. And some of those adults, if they can't clear with that, have even, gone as far as clofarabine, and that is actually cleared, at least in my experience, disease in adults, and then they can kind of finally be done with it and get back to normal life. But the adult patients are really interesting.
Yep.
They have a different disease.
In the chat box, Michelle, you wrote something which to me is very interesting. You wrote, in the US, having LCH classified neoplasm is advantageous as it opens up a number of family resources that are only available to children with cancer. I think I finally understand why Carlos still says that this is a neoplasm. Because you see, in Singapore, the situation is different. Yeah, we had this new patient with LCH just about 1 month ago. So I was told that the father is worried that the child may have cancer because he has been doing his homework. Yeah, he found some papers that describe LCH as neoplasm. So here we try not to frighten the kids and the parents too much. Yeah.
Okay. I just moving on to the next question. Thank you. So maybe to Michelle, in multi-organ non-CNS disease, what do you think would be the most important investigations to decide on remission?
I'd be curious what Carlos and Prof. Kwa think also. I mean, it depends with multi-organ disease, if they have organ involvement that affects like their LFTs or things, those are helpful to monitor. I actually like PET scan for following patients, and I've actually recently moved to full body MRI in any of the kids who can do that without anesthesia. And usually in our MRI machine, they can actually see movies and stuff. So we've had kids as young as 3 or 4 do whole body MRI. But that's been very helpful. I don't like to do it with anesthesia because the anesthesia is probably more risk than the radiation exposure of doing other kinds of imaging. But that's what we've been using.
Prof. Kwa and Carlos, do you have anything to add to that?
No.
No. I think that we are moving to the same, just minimize radiation, do whole body MRIs when possible. PET scans can help you a lot in case of doubt. And then for patients with, risk organ involvement, if you have liver disease, bone marrow disease, obviously you need to target, assess liver function. You don't have good imaging for liver. It's just how the liver improves in function, in size, and the same with the bone marrow function. It's a clinical judgment in those cases.
Okay. Maybe just one question along with the questions about liver impairment, liver transplant. Do you think, I mean, what would be your practice before you consider a patient for a liver transplant, the indication to move towards a liver transplant, and if it's ever been done? And also bone marrow transplant, when would you consider that this LCH patient would require a bone marrow transplant? Maybe Carlos?
Yeah, I can. Yeah, I can tackle some of these, but I would like to hear as well Prof. Kwan and Michelle. So liver transplant. Yeah, I have had a patient one that I had to transplant, and so I had the moment of, as we were saying, you know, when active LCH ends and when long-term biliary cirrhosis starts, oftentimes it's not so clear. If you have a patient that has been treated for 2 years, 3 years, you don't see any other signs of disease, the sclerosing cholangitis has progressed, you do a biopsy and you see biliary cirrhosis, no evidence of LCH, that's a very excellent case for transplant. Then the criteria for transplantation would be whenever, you know, whatever the criteria for transplantation are in the transplant program, usually is end-stage liver disease. These patients tend to have severe portal hypertension, bleeding, etc. The question oftentimes happens when you still are not convinced that the patient has not been in remission yet. So when you still feel like there is disease in the lymph nodes, in the skin, in the bone, when is the time for transplant? And usually, even if you want to, the transplant programs, the transplant surgeons would not accept a patient with active LCH for transplant. So that's the major problem I see. So in general, try to, now that we have BRAF inhibitors, that it's easier. So I think that you can put a patient in remission and then move the patient to transplant. So that's my point. And for bone marrow transplantation, right now, very few cases go to bone marrow transplantation. Just now we have better therapies. So in LCH4, we had this study open for many years, as Michelle knows. We haven't had one single case transplanted. So.
Thank you.
Okay, Michelle.
I haven't had the liver experience where oops, you're muted again.
Yeah.
We haven't had the experience of having to do, at least in my own personal experience, of having to do a liver transplant. But I think it would be this, one of the downsides of it now being a cancer in the United States is that would fall under the same rules as malignancies, and there would be, you have to wait to be clear of disease. In terms of transplant, I've only had 2 children that I typed because I was worried because they had failed everything and had very significant multi-system disease. And clofarabine worked beautifully for both those kids. And both of them they were young kids, and they're now 3 and 6 years out from therapy. So doing great. So I haven't had to transplant anybody.
Yeah. The liver involvement used to be very scary for me because of the 4 deaths I had so far. The one died of the marrow involvement. Yeah, finally this girl ended up in DIC and then nothing worked for her. The other one died of a neurodegeneration. Yeah, but the other 2 were the severe liver involvement. And these kids didn't respond to treatment at all. So I used to be very scared when I see liver involvement, but the 2 more recent cases have done well. Both of them have stopped treatment. And as Carlos said, even if the liver disease become quiescent, you know, you can still be left with liver fibrosis. Yeah, so this girl who is about 5 years old now have hypersplenism. The liver is a bit hard, but the liver functions all return to normal. So of course, this sort of patient will not need the liver transplant. Yeah. So the other one I was a bit quite worried too because there's some features of obstructive liver disease, but surprisingly the involvement when you do an image of the liver was only a small segment. Yeah, which finally did resolve too. So as I said, this is so individual. There's even among kids with the liver involvement, there are so many the different varieties. So again, we got to look at each child as individuals and reassess. Yeah, so we haven't had, in fact, if we could settle these 2 kids who died, then these 2 kids would deserve liver transplant. But unfortunately, these kids were just too sick.
Thank you. Maybe we'll just take the last 2 questions. So from Alexandra Pangar. So maybe to Prof. Kwa, we have LCH patient with a meningocele. During the treatment, the osteolytic lesion progressed. Should we do temporary cranial flap or proceed with chemotherapy?
You see, there's one point I'd like to raise. The LCH is something that we should work very hard about, because many patients had been managed poorly because the diagnosis wasn't made early enough. Yeah, I'm sure all of us have seen kids, for example, who had cranial flap, and they see the neurosurgeon, and neurosurgeons, they love knives. Yeah, so they just cut out the bone and replace something, yeah, which is entirely unnecessary. We have also seen kids with skin involvement, 2 years, eventually the developing into the ulcer. And the doctors who have seen these kids, many of them, they didn't listen to the mother when the mother told them, my daughter has been passing a lot of urine, drinking a lot of water. So it didn't ring a bell in these kids. Yeah, so this poor girl suffered for 2 years before the diagnosis is made. So I'm sure almost all the patients that we see never come to us as initially. They see the dermatologist, they see the endocrinologist, they see the ENT doctor. Yeah, so this reminds me of the situation in retinoblastoma. You know, the awareness is so important. Hopefully awareness among the non-PICS onco doctors. Yeah, that there's such a thing as LCH. That the presentation is usually quite classical. Yeah, so then you should recognize it early and refer to the right people. Yeah. So then the question is, the cranial flap. I don't think it is necessary, because suppose if it is just a bone lesion alone, there are so many drugs that we can use. As the Carlos pointed out, if penicillin or the vinblastine don't work, I would use the biphosphonates or indomedacine, depending on the family's circumstances. Yeah, I don't think that any of these kids will need a cranial flap. You see, if these kids have the lesion, at certain places like the femur, the tibia, yeah, they are at risk of fracture. But the cranium is okay. You know, yeah, so parents may worry that there may be brain injury to the brain, but you just tell them that the brain is a tough organ. It's covered by this membrane called dura mater. Dura means it's very tough. So it's not necessary. Yeah, back to you, Francis.
Okay, I think Dr. Trisha will take this last question from Dr. Trisha. Hi. What is the rate of secondary malignancies in LCH? Any one of you?
There is an association with cancer with LCH. I have a patient with LCH initially. After finishing treatment, he developed some bone lesions in the pelvis and turned out to be LCH. I didn't know about that, so I read up the journals, and indeed there is an association. I think in Carlos' paper, he also mentioned association with the ARL. Yeah, and one of the drugs used to treat LCH long time ago was etoposide. It works well, but because there are other drugs which work equally well, so we have stopped that, because etoposide is well known to cause secondary the AML. Yeah, so some association is genetic somehow. The other association is the long-term side effects of the chemo that you give. Any addition, Carlos?
No, I think you said it very clearly. I think there are associations with other malignancies, but it doesn't mean that these are second malignancies. And so in pediatrics, the only one that has been associated genetically is ALL, usually T-cell ALL, but that's the only one.
Yeah.
Okay, I see a few more questions, but maybe in the interest of time, we will just collate the rest of the questions in the Q&A, and then we will answer subsequently in the forum. And maybe Teresa, I will just hand it back to you. Thank you everyone for joining us this morning, this evening, wherever you are in the world. Thank you, Carlos, for presenting such a enlightening talk to all of us again. And maybe I would just like to take this opportunity to just let everyone know that we will be starting an Asian histiocyte disorders collaborative group that will be spearheaded by Prof. Kwa and as well as Michelle. So we just want to really increase awareness. The aim is just to increase awareness across, especially in Asia, where resources are less readily available. We would like to be able to discuss and educate our colleagues about management of these complex conditions, where sometimes the diagnosis is often missed and the diagnosis is made late, where resources are less readily available. What is the best method, again, for investigation and to document remission and clearance, and also in cases that are difficult to treat, to get expert opinion again as to what would be the next best line of therapy. Thank you.
Maybe just something, those who want answer to their question, I think they can send me an email. Don't disturb Carlos, he's very busy, and Michelle too. Yeah, I know she's doing 100 things at the same time.
Okay, well, I think that includes our webinar for today. Thanks to everybody for tuning in. So a big thank you once again to Dr. Galindo, Francis, Prof. Kwa, Michelle, for this very informative and very insightful session. So we hope that everyone found this webinar useful, and would like to invite everybody to kind of help us to fill up the survey form. And if you'd like to join our upcoming webinars on the 14th of October and the 27th of October, you can check it out on our website at www.viva.sg. So I think we'd like to thank everybody for coming, and we look forward to welcoming everybody in future webinars. So thank you and have a good day. All right.
Thanks, Lisa. Bye-bye.
Thank you, everybody.
Thank you. Bye-bye.
Bye.
Thank you. Bye-bye.